Hello, everyone. I am Justin Schwartz. I am a developmental behavioral pediatrician at Children's of Alabama and UAB, and assistant professor of pediatrics at UAB. And I am delighted to be speaking with you about the medical evaluation of children with developmental delay. I do not have any financial disclosures. I do not intend to discuss any non-FDA approved uses of products or services. I have no relevant financial relationships. The first step towards evaluating children with developmental delays is to identify the children with developmental delays. One of the most important things that I can convey, even before starting talking about the evaluation of kids with developmental delay, is first being able to be receptive to parents when they come and say, "Doctor, I'm concerned about X, Y, or Z related to the child's development." Parents are always the experts in their children until proven otherwise. So it all starts with the history. Any medical evaluation can't happen without really listening to the parent or the caregiver and using the parent's chief concerns as a point of common understanding. Acknowledging that as pediatricians, we are the experts in children. The parent is the expert in his or her child. And our task is to put together our two areas of expertise to be able to make the right recommendations for the children. Also, along those similar lines, as a pediatrician, you should be able to feel comfortable with the concerns that you may have regarding a child's development or behavior. If something doesn't add up to you, for example, a speech and language delay or a problem with motor skills or development, regardless of what the parent's perceptions may be, in the cases that parents might not necessarily be clued into their child's development, as you might be as someone who sees a lot of kids over a long period of time, then you should absolutely feel comfortable sharing your concerns with the parents, regardless of how you may perceive those concerns to be received, because it all starts with a good dialogue between the provider and the parent, as everyone knows. So definitely listen to the parents and the caregivers when they have concerns with developmental delays, because you can obviously gain a lot of information from that. So what specifically should you ask about, specifically related to developmental delays? There are a lot of things that you can ask about in the history that may clue you in to other medical things that might need to be done. For example, feeding is a big issue in kids with developmental delay. Figure out what the pattern is. Do they have an increased appetite? As we might think, if a child has an increased appetite in developmental delays, the concern for some particular conditions, like Prader-Willi syndrome, might arise. Alternatively, a child might have a decreased appetite. And what may be seeming like a decreased appetite may also be something like selective eating for a variety of reasons, whether it's texture, preferences or aversions, taste issues, being able to handle food mechanically with the tongue or the mouth, and also previous experiences with gagging or choking. Also ask about functional feeding skills, using utensils, using whether or not they can drink out of an open cup if it's developmentally appropriate for them, using straws versus a preference for using hands are always important to assess to make sure you're getting a true picture of how the feeding is going. Also, you can ask about potentially abnormal feeding behaviors. For example, if a child is exhibiting pica or eating or mouthing non-food objects. That can be very important. Also thinking about the parent-child interaction with feeding. Are there a lot of battles taking place? Are there developmental expectations that the parents have that aren't necessarily met by the developmental capabilities of the child, and battles ensue? Those are all very important things to planning what interventions or medical workup might be necessary for children with developmental delays. Also think about a sleep history. This is incredibly important when thinking about a medical workup for children with developmental delays. As we all know, sleep affects everything. It affects development, it affects learning, it affects behavior, it affects the parents. If the kid's not sleeping, the parent is not sleeping. So being able to take a thorough sleep history can also tell us what we might need to do medically to make things better. So thinking about bedtime versus sleep time. When are they getting in bed? How long does it take for them to fall asleep after they get into bed? Are they taking a nap during the day? How much time are they spending taking a nap during the day? Is there a routine? Are they engaging in pre-bedtime activities that are soothing or calming as opposed to activating, like screen time or exercise or other things? What are the mechanics of sleep like? What is their sleep environment? Is it consistent throughout the day or throughout the night? Are they starting their sleep in the same environment that they could potentially be waking up with during the middle of the night? As we know, a lot of kids with developmental delays also have anxiety. And we know that kids with anxiety, regardless of their developmental history, thrive when their sleep environment is the same when they fall asleep versus when they could potentially wake up in the middle of the night. And as we know, all kids have nighttime arousals. Ask about snoring or gasping in sleep. These could potentially be symptoms related to obstructive sleep apnea, which, as we know, can affect a number of issues during the day. Also ask about particular sleep behaviors that the kid might be exhibiting. How many times are they waking up at night? What are they doing when they wake up at night? What do the parents do when they wake up at night? Is the child having night terrors or nightmares? Is the child restless? Is it a kid who is active during the day and also really active when they're sleeping at night? Are they kicking the covers around? Are they thrashing about, throwing themselves off the bed, waking up in unusual positions? As we'll talk about later, that might clue you into some medical conditions that we could investigate in the primary care office and do something about and potentially make the sleep a whole lot better. As always, take a developmental history. Developmental histories, again, if a child has developmental delay, are important. I'm not going to focus a lot of time on the specifics of the developmental history, assuming that we've already identified the kids who have developmental delays through screening or other measures that U.S. practices are participating in. But I will emphasize the need to understand red flags. There's a great CDC program called Learn the Signs, Act Early that is geared towards autism, but is able to convey a lot of red flags that you can look for at various ages to really be clued in that there is something that we really have to investigate further. Always ask about regression. Regression is losing skills that the child has attained for sure. We're not necessarily talking about a kid who may have started saying mama, mama, ma, and then kind of stopped saying that. But for example, if a child is saying 5 words that they can use functionally, so juice, ball, things like that they're using to request or to name other things, name other objects functionally, and they stop doing that, that's a true regression. Or if they started taking steps and then all of a sudden they're not getting up on their feet anymore. Those are true regressions, and those would be very, very important to key in on, and usually they're not subtle. Also think about splinter skills, and by splinter skills, I mean skills that a child is exhibiting that may not necessarily be developmentally appropriate. Usually splinter skills are skills that might seem advanced or precocious, but in fact may represent deviated development rather than developmental delay. So for example, if a child has not yet started saying mama, dada, but they're saying words like cornucopia, that's not necessarily an indication of precocious language development, but might indicate deviated language development. So it could be potentially a splinter skill if they're naming these really advanced vocabulary skills, but have not necessarily gone through the typical developmental progression. Those might key you in to an underlying developmental condition that would obviously need further workup. What should we ask for when we're getting a medical history? As always, knowing the birth history is very helpful because we can certainly evaluate for conditions either prenatally, perinatally, or postnatally that might be indicative of a reason as to why a child might have developmental delays. And there are a number of reasons. Asking about frequent or recurrent illnesses can be important to know, especially if a child is having developmental delays alongside of their medical conditions. Obviously, if a child is being hospitalized frequently, that can certainly have an impact on typical development as well. But asking also about more intense than expected illnesses. If a child gets a virus and seems to really crash and burn with each virus, or gets a stomach bug that seems out of proportion to the severity that other children around that particular child have experienced, could clue you into potential metabolic disorders. Thinking about the fact that the energy demands of the child are increased when a child is sick and the kid can't keep up. Always ask about seizures or staring spells. This can be a little bit tricky in kids with developmental delay, especially kids with autism, who might exhibit stereotyped behaviors or repetitive behaviors that might look either jerky or episodic, but may in fact represent more kind of stereotypic or repetitive behaviors. Staring spells, obviously you want to ask about the particular type of staring spells that you see in absence seizures, where a child might be involved in something and then stop, stare off into space. They may smack their lips or move their hands in a stereotypic way, and then immediately resume what they were doing before, as if what I like to ask about the child being put on pause. Always ask about GI symptoms. We know that in kids with developmental delays, there is a much higher rate of GI symptoms. So nausea, vomiting, diarrhea, constipation is a huge issue, especially when the kids with developmental delay who are picky eaters. So always make sure we ask about GI symptoms. Ask about endocrine concerns, thinking about, again, possible thyroid abnormalities. So thinking about weight gain, unusual hot or cold intolerances, constipation, dry skin, or difficulties gaining weight, things like that. Rashes and skin changes are always important to ask about, especially if things are changing or if things have been present for a while that may clue you into an underlying neurocutaneous disorder. And also thinking about, again, in general, growth or weight concerns. So if a child has had trouble gaining weight, gaining too much weight, is not achieving the height velocity that you would expect on the growth chart, can always inform what potential medical workup that we can do for a child when investigating developmental delays. A good family history is important to determine whether or not there's a particular inheritance pattern that we can pick up on. Consanguinity is important to ask about because that increases the likelihood of manifesting an autosomal recessive disorder. In general, the conditions that I typically ask about in the family history are anyone in the family who's had any type of developmental delay, learning problems, needed services as a young child or as a child in school. Asking about emotional or mood problems, so anxiety, depression, other mood conditions, bipolar disorder in the family. Of course, you have to be a little bit careful when asking about bipolar disorder and want to make sure that it is a true manifestation of mania and depression, because I think the word bipolar is often attributed to other emotional or behavioral concerns that may not necessarily reflect true bipolar disorder. But other psychiatric concerns such as schizophrenia or psychosis or other behavioral conditions, conduct disorder, folks who are rule breakers, have been in prison, things like that are always important to know about in the family. Asking about neurologic conditions, so anyone who has epilepsy or seizures or has had other brain malformations or brain problems. Cardiac conditions are very important to ask about because of a lot of the association between cardiac conditions and genetic conditions, but also in thinking about the child potentially, if it's an older child and there are behavior concerns, we want to ask a targeted cardiac family history, especially if we're thinking about putting a child on stimulant medications. So asking about sudden death while exercising, heart attacks at a young age, less than 40 years old, single occupant car accidents, things like that can clue you in to a potential workup, and we'll talk about that a little bit later. Also asking about a pregnancy history, so specifically things like miscarriages. If a family experiences a lot of miscarriages, that might clue you in that there might be a translocation that may be balanced in some but unbalanced in potential offspring that may be resulting in frequent miscarriages. So that's a very important piece of the family history to know. So a physical examination, we always get weight, height, and head circumference. I will stress that head circumference is important, especially if you have a child who is suspected of having developmental delays. We always want to make sure that we are doing a good head circumference. And in the picture here, you can see the correct way of doing it. You want to make sure that you measure the head circumference at the point of maximal protuberance, so to speak, at the occiput, and also going across both temples and across kind of the front part of the forehead. But documenting either macrocephaly or microcephaly can be incredibly useful, and also tracking that as the child gets older, especially in a child with developmental delays. What else do we do on physical examination besides the typical physical examination stuff? Look for dysmorphology. There are a lot of resources that U.S. pediatricians can use to help you in determining whether or not a certain feature might be considered dysmorphic in a particular child. There's a difference between what we would call major malformations or anomalies, which are obviously clefts, spinal cord defects, big things that you don't have to look hard to find. But then there are also things that are called minor malformations. So minor malformations are things such as multiple hair whorls, or ear abnormalities, or subtle finger abnormalities like clinodactyly, that can inform you that, especially in constellation, that we might be interested in some genetic workup for the child. In particular, if you suspect autism, there is a measure that you can learn about and do in your primary care offices that can really inform the decisions you make regarding medical workup. There's the autism dysmorphology measure that was published by Judy Miles at the Thompson Center in Missouri that goes through basically 12 body part regions and provides an algorithm that can tell you whether or not a child meets criteria for being what you would consider a complex case, or somebody who has dysmorphology versus a, quote, essential case where somebody does not have overt dysmorphology. And again, that might suggest differences in not only etiology, with the thought being that kids who have a lot of dysmorphology that's able to be found on this measure have a more embryologic problem that's associated with their developmental delays versus something that might be completely different. A careful neurologic exam is also very useful. We always look at muscle bulk and tone. We think about the strength and symmetrical movement or symmetrical strength. Always look at deep tendon reflexes, especially in a kid who has motor delays. Think about coordination, tests of coordination in young kids. That may be simply reaching out, grabbing objects, transferring objects between hands, things like that. Looking for primitive reflexes. Again, you have a persistence of primitive reflexes in cerebral palsy and other central motor abnormalities, that would be very helpful to document and might provide, again, some guidance on what we should do for a medical workup. Also think about looking at them walking versus them just standing, so-called gait and station. If somebody has a gait that looks concerning for, again, toe walking or a spastic gait, obviously those would tell you something about the child. But looking at station as well, do they have a lot of lordosis or kind of swaying their back when they stand up? That might clue you in on potential muscle disorders or neuromuscular disorders as well. There's a helpful resource that I've provided at the bottom of this slide that can teach more details about the pediatric neurologic exam and how to do it in a systematic and reliable way. So I encourage you to check that out if you are interested. A good skin examination is something that we always stress. The skin being a window into some potential neurocutaneous disorders that can present very subtly even. So look for things like macules, cafe au lait macules, rashes that have been persistent or characteristic. So tufts of hair at the bottom of the spinal cord, things like that. A Woods lamp exam is an exam that uses a UV light that can particularly look for ash leaf spots or other hypopigmented lesions that might clue you into something like tuberous sclerosis. An abdominal exam can show you organomegaly, again thinking about a big spleen or liver, in conjunction with some other findings that could potentially say, hey, we might need to do metabolic testing in a child who has those particular features. And a genital exam is always important as well, thinking about things like macroorchidism that you can see in something like Fragile X. Not necessarily apparent at young ages, but of course when they get older you can certainly see that. Or hypogonadism, which again can suggest particular genetic syndromes like Prader-Willi. Penile macules, these are again little spots on the penis itself that in some conditions you can see. For example, if a child has a large head and you look at the penis and there are penile macules, that may suggest a particular genetic test, like a P10 gene analysis, P10 being PTEN gene analysis, which can clue you into overgrowth syndromes. Looking for hypospadias can also be kind of a sign of subtle dysmorphology. And also looking at the sexual maturity rating, especially as kids get older and kids with developmental delays, there is some tendency in certain conditions where you can have precocious puberty, and that would be important to assess for. And also, even if it's not precocious, in kids with developmental delay, you want to know how puberty is progressing so that you can do appropriate family counseling regarding the potential reproductive potential of the particular child. So what do we do for a medical workup once we've done all of that? One of the most important things that we can do and make sure of is that the child does not have any sensory deficits. So doing an audiology assessment, making sure that they can hear. And it's really important that we do an audiology assessment who can use the appropriate either behavioral or electrophysiologic measures to be able to really tell us something about the child's functioning. If a child has developmental delays and they're doing hearing screening either in the office or at school, it may not necessarily be as useful as a thorough audiologic assessment. So if there are concerns about developmental delays, go ahead, refer to audiology. Make sure we got that piece done. Also thinking about a good vision and eye exam, referral to a pediatric ophthalmologist who can do the appropriate examination and determine whether a child has good functioning vision or whether there may be other vision considerations like strabismus or retinal issues that can present alongside of developmental delays. A genetic evaluation. So it may be something that might be a little bit scary to do in the office, especially when thinking about getting blood from a child, making sure you get the right blood and make sure you get all at once. So we're not doing multiple blood sticks, but there are certain things that you can certainly think about, especially if you have a kid who you're very concerned about developmental delay, you're finding some dysmorphic features. One of the most highly recommended and, in fact, standard of care genetic tests for kids with developmental delay is the chromosomal microarray. Again, if you're seeing a kid with developmental delay, it doesn't hurt to go ahead and talk about this with the families, knowing that that's probably going to be somewhere in the kid's future. In kids with autism, we know that the yield with a chromosomal microarray is about 10%, so it's not insignificant. We would recommend other tests depending on the presentation of the child. In children with developmental delay, often Fragile X is standard of care, especially in boys. And in fact, the two most commonly ordered genetic testing that we do as developmental pediatricians are the chromosomal microarray and the Fragile X test. There are difficulties in identifying Fragile X when kids are young, and especially when all you have is nonspecific developmental delay. Especially young kids don't necessarily have the typical facial features or, again, the macroorchidism that we talked about before. So having a high level of suspicion for this is important when thinking about a medical workup for the child, because if you find Fragile X syndrome, it can potentially change the way that you talk about the developmental delays, not only about the child, but also about the family at large, knowing that kids with Fragile X are born to a parent with a premutation, which also has its own implications on medical and psychological care in the future. Again, I mentioned the P10 gene mutations. Again, thinking about kids who have a large head circumference. Again, this is going to be a kid who has a head circumference greater than the 98th percentile and developmental delays, especially if you have concerns about repetitive behaviors or other signs of autism. We would often think about P10 gene mutations. And again, if you see P0 macules, think P10 gene mutations. Chromosome 15 methylation disorders, these are Prader-Willi syndrome and Angelman syndrome. If you have a history that's concerning for Prader-Willi, again, hypotonia at birth or almond-shaped eyes or hyperphagia, eating a lot, then we can think about ordering those tests. MECP2 testing is indicated if you have a clinical suspicion of Rett syndrome, thinking about girls who have the progressive development of microcephaly and stereotypic behaviors and developmental regression after a period of what seems to be like normal child development. Whole exome and whole genome sequencing are things that are on the horizon and are being used mostly in research purposes. We don't do these clinically routinely, but here at UAB we have partnerships that allow us to do whole exome and whole genome sequencing as part of studies. So I mention it, and it's certainly something that if it comes up that parents are reading about and are inquiring to you about that, you can certainly relate some information about whole exome and genome sequencing. The yield in children with developmental delay in general is about a third, and that means in a third of kids we're finding meaningful genetic results using whole genome sequencing that we weren't otherwise able to find using our standard chromosomal microarray or other tests. But that being said, it's very expensive and has not yet made it to clinical use because of those restrictions. When should we consider metabolic testing? As a developmental pediatrician, I don't routinely do metabolic testing in children with developmental delay, knowing that the yield for metabolic testing is quite low, less than 1% generally. But in certain cases, with certain considerations, metabolic testing is appropriate. So thinking about if you have, again, a true regression, either without an illness or fever or with an illness. So if you have a child who has true developmental regression after they get sick, it might be appropriate to think about metabolic testing. If a child has seizures, there are lots of metabolic conditions that predispose you to seizures as well as developmental delay. Failure to thrive without another obvious cause, thinking about, again, the inability to utilize the energy that's being taken in, can clue you into doing metabolic testing. If you do electrolytes and you find that there's an acidosis that's not otherwise explained, then that might be related to a metabolic condition. If you have a macrocytic anemia, that's related with some metabolic conditions. And if you also have a kid that just seems to have a lot going wrong in a lot of different areas, so multi-organ symptoms, then you can certainly consider metabolic testing. There are some conditions like Kabuki syndrome that are not necessarily metabolic, but also have multi-organ involvement as well. But I think in general, if you have more than one organ system that seems to be not functioning as physiologically expected, then you can certainly consider metabolic testing. And by metabolic testing, those include things like serum amino acids, urine organic acids, acyl carnitine profile, carnitine deficiency studies, or other basic metabolic tests. And there are practice guidelines in the American College of Medical Genetics from 2013 that you could potentially use to help guide you in decision-making on what tests that you can order in your practice. Other blood testing might be indicated for various concerns or symptoms. A complete blood count, or CBC, could be useful. Again, thinking about, we just talked about macrocytic anemias, or if a child has picky eating and you want to screen for anemias or iron deficiencies. Again, thinking about iron studies along those lines can help you determine whether or not a child might be meeting those dietary needs, which can obviously have implications on a child's cognitive development and development in general. A serum ferritin I mentioned in particularly because the serum ferritin is associated, if it's low, the serum ferritin is associated with a child feeling like they might have restless leg syndrome. And when you're taking a sleep history, I mentioned a kid who might be thrashing about and throwing the covers everywhere and being really, really restless in sleep. And when we hear that history, that may be because the serum ferritin is low. The typical clinical practice regarding serum ferritin is that if it's less than 50 and a child is exhibiting a lot of restless sleep, their sleep quality might be low and might be related to their serum ferritin being low, which might mean that treatment with iron at treatment doses might yield better sleep and in turn better development and better behavior during the day. If you have a concern about thyroid studies, especially if there are certain signs or symptoms that could be related to thyroid dysfunction, making sure you rule out thyroid function studies in those particular cases is important. And thinking about lead screening, especially if a child has risk factors of pica or living in an old house, if they've had previous lead screens that have indicated high lead levels, always making sure that you do lead screening as appropriate. In fact, if you have a child with lots of mouthing behaviors, and they also have other risk factors like living in an old house, then it might be worth doing lead screening yearly in some of those kids. And other nutritional deficiencies such as vitamin D or other vitamins as deemed appropriate can also help guide intervention as well. When do we do head or brain imaging? In our population, head or brain imaging is not easy to obtain. There are a lot of considerations that we have to think about. The principal one being safety. Our children generally usually have to be sedated, especially if they have developmental delays. And so it's always a discussion related to the risks and benefits of doing head imaging. When I think about doing head imaging is when I have a kid who has microcephaly. That's pretty consistent, and developmental delays, or a rapidly changing head circumference, obviously. If a child has focal seizures, it may be worth doing head imaging to identify a particular locus that may be either malformed or not functioning right, that may lead to the thought about intervention. Or if there are focal neurologic findings, it might be worth doing head imaging just to shed light on why a child might have these focal signs. But in a lot of cases, head imaging for children with just general developmental delay without any of these other issues doesn't necessarily yield anything for us that we can potentially act on. It might potentially lead to some finding of a structural abnormality that we could say this could be related to the developmental delays, but again, it might not necessarily inform our interventions. And so, again, it is a risk-benefit ratio analysis when thinking about doing head imaging, and it's not something that we routinely do, although at some point it may potentially work its way into something that we are doing more often. But at this point, if the risks outweigh the potential benefit, it's probably not worth doing. EEGs are indicated when you have a positive history of concerning staring spells, or if you witness a staring spell, that would always be advisable to get an EEG in that case. If you have true seizure-like activity that does not seem to be either repetitive or stereotypic behavior, unexplainable periodic behavioral outbursts could potentially be a sign of a seizure that's in a part of the brain, like the frontal lobe or temporal lobe, that manifests in behavioral ways, not necessarily your typical seizure like semiology. Or if there's a history of distinct language regression. And this is important because it might suggest underlying specific conditions. There's one called Landau-Kleffner syndrome that's characterized by a language regression around 3 or so years of age because of the fact that the child is having seizures while the child is sleeping. Again, we're talking about true language regression, so functional word use stopping or significantly diminishing. And in those cases, you would consider an overnight EEG, making sure that you capture slow wave sleep and make sure the child is not having seizures, because that is something that's potentially treatable. And of course, if there are concerns and you would like for a subspecialist to evaluate the child, that is always a valid option. Again, developmental behavioral pediatrics is a good resource to help guide medical workup for children, and other subspecialties as deemed appropriate, neurology, if there are concerns about seizures or focal neurologic signs, genetics or metabolic specialist if you're noticing particular signs or symptoms either on your physical exam or the medical workup, as we talked about, indicates the potential for either a genetic condition or a metabolic condition. Referral to psychology for further clarification of a kid's cognitive or developmental level or for more specialized evaluation. Or other subspecialties as needed, endocrine or cardiology, whatever the medical work that you've done indicates is necessary. What do we do in developmental behavioral pediatrics? This is something I like to go through just because not a whole lot of people, I think, out there are familiar with what we do in developmental behavioral pediatrics, and we do exactly what you would expect. We take a thorough developmental and medical history, incorporating a lot of the elements that I've already talked about in this PowerPoint presentation. We do a thorough medical examination, including a full physical examination, including dysmorphology, neurologic, skin examinations. We do developmental testing as appropriate. A lot of us will do the Autism Diagnostic Observation Schedule, or we'll do developmental testing to try to quantify at what age a child is functioning at, or we'll do adaptive testing to document kids' functional skills. So we do a variety of developmental testing, and we generate a comprehensive report as well as recommendations for either medical workup or treatment or services or other things that the kid might need. Currently we have two developmental behavioral pediatric clinics at Children's of Alabama. We have the Developmental Medicine Clinic, and the website is listed here. It is a general clinic that sees kids of all different ages with any particular developmental or behavioral concern. In that clinic, the child is usually seen just by a developmental behavioral pediatrician. It is not a multidisciplinary clinic, unlike the medical autism clinic, and you can learn more about that at that website, which is a clinic that sees children up to age 9 who have either a concern for autism or have already been diagnosed with autism, and there are questions related to other medical or developmental or behavioral issues related to the autism. And that clinic has developmental pediatrician, it has geneticist, it has speech therapy, occupational therapy, nutrition as needed. So it is a multidisciplinary clinic. And those are the clinics at Children's of Alabama. Of course, there are always the other resources here at Children's and UAB, like the Civitan Sparks clinics, or psychiatry or children's behavioral health that are also referral targets as well. And that is the end of the presentation. This is me, and that's my phone number and my email. I am certainly open to taking any questions that you may have about any particular children or questions about developmental behavioral pediatrics in general. So feel free to ask me questions at any time, and I hope that this presentation was informative, so thank you for your attention.